All right, so we're going to demonstrate how to use the InSpace implant. We have a right shoulder here. This is a cadaveric demonstration. You can see I'm in the subacomial space. We've created a massive rotator cuff tear to approximate the surgical setting in which this device would be used. Here you can see the glenoid, the humeral head, the edges of the remnant of the rotator cuff. The biceps has been released in this situation. Here's the greater tuberosity, the lateral margin of the subacomial space, and then as we look up, you can see the undersurface of the acromion and the lateral margin of the acromion. It's important to recognize that, as we've discussed during the introduction, there are multiple causes of shoulder pain that can include things like biceps pathology, AC joint pathology, impingement, and bursitis. And we need to make sure that we evaluate each of these potential pain generators and address them as needed given the patient that you're dealing with. So once we've established a clear visualization within the subacomial space, you can see here the remnant of our rotator cuff. Here is the glenoid, the remnant of the biceps, the lateral margin of the tuberosity. The first thing we're going to do is use a graduated measurement device in order to size the implant that's appropriate for this patient. In this setting, what we do is to start about 1 centimeter medial to the margin of the glenoid, and we're going to measure to the lateral margin of the tuberosity. And in this situation, we've measured that at 55 millimeters. Now, the device is sized based on your measurement, and in this situation, once we have a measurement greater than 50 millimeters, we would select a large size implant. So this is what our back table looks like. You can see that there's really minimal instrumentation that's required. You need the basic instrumentation that you would use for any arthroscopic case, which includes an 11-blade knife and a spinal needle. Well, you can use a variety of different shavers or bone resection tools if an acromioplasty is to be considered. But basically, there is no specialized instrumentation that's required. Here we have the implant, the syringe that holds the saline for implantation, but that's about it in terms of the actual equipment that's necessary. We've now measured, and we're going to use a large implant. As we mentioned in the introduction piece, the implant comes loaded on a deployer. Once you open the package, the entire construct is already assembled and sterile and ready for use. So there's a couple of different portions of the implant that you should be familiar with, including the insertion tool. This is the insertion handle. This green tab is actually the deployment tab that will be used when you're ultimately ready to deploy the device within the subacomial space. The red lever here just prevents you from doing that prematurely. This is a backstop device that prevents you from prematurely exposing the device. In this case, I'm going to flip it up just so you can see how we can now slide down the sheath, and that exposes the balloon, which is ready for deployment within the subacomial space. So when you unpackage the device from the sterile packaging, it will essentially look like this, and that will allow you to place it into the subacomial space using this alignment line to make sure that the device is fully placed positioned appropriately within the subacomial space. Okay, so now we're ready to come back to the shoulder and actually place the device in the subacomial space. The first thing that we're going to do is just slightly expand our lateral subacomial portal. I would say that you want it to be approximately 1 centimeter to maybe 12 millimeters. And then I'll actually use a hemostat that comes into the subacomial space, allowing me to dilate into the deltoid just to provide a clear pathway for the device to be implanted, as you see here. The next step is to actually take the device, bring it to the field. Remember that as long as this red backstop is in place, it will prevent you from prematurely exposing the device. So we're gently inserting the device into the subacomial space. If you do encounter bleeding, it's generally minimal and can be controlled using a standard radiofrequency device or adjusting the pressure on your pump. It's also helpful to ask your anesthesiologist to maintain the blood pressure as close to a mean of 100 as possible. You can see as I'm inserting device, what I'm doing is keeping an eye to this alignment line that's present on the insertion sheath. And I basically need to make sure that I'm visualizing that within my arthroscopic view within the subacomial space. And once I see that within the space, I know that the device is fully placed within the space and ready for deployment itself. Now, before we release this backstop protector, the first thing that we're going to do is to attach the tubing connected to our syringe. Our syringe is filled with 0.9 saline. Because of the size of the device that was selected as large, we've pre-filled the syringe with 40 cc's of saline to be prepared to fill and then deploy the balloon. Once we've got the saline in place and we're comfortable with the position of the device within the subacomial space, we're going to release the backstop protection, slide it down, and I'm going to slide back the sheath which is now going to expose the balloon. And again, with clear visualization, I can clearly see that the device is, the implant is clearly within the subacomial space and in the appropriate position. So at this point, once you have the device exposed within the subacomial space, you really are committed, and there should be no manipulation of the implant itself, or you could risk perforation of the balloon. If you had a problem at this stage, it would be best to remove the entire implant and start over with a new deployer and implant itself. Here you can see the balloon is now in the subacomial space. We've removed the sheath to expose the balloon. My assistant has the syringe hooked up with 40 cc's of saline, and we're now going to begin to gently inflate the balloon. So in this case, based on the manufacturer recommendations, we're going to place the entire 40 cc's of saline into the balloon itself, and then we'll remove 15 cc's of saline in order for the appropriate setting to be reached. And we're now going to begin to gently inflate the balloon. The device itself, we go to the predetermined volume based on the size of the device. You're going to insert the entire volume and then back off to the manufacturer's recommendations. And here you can see the device inflated within the subacomial space. Okay, so now once you have the implant which is appropriately inflated within the subacomial space, you can see that we've clearly visualized the inflation here on the arthroscopic view, as well as check to make sure that we've inflated to the appropriate volume. We're now ready to actually deploy the implant. To do that, we press this red button in order to free up the insertion knob, and then we simply slide the insertion knob all the way until we feel a click. That will seal and release the balloon, allowing us to remove the insertion handle, leaving the balloon in place. Once we have the implant fully deployed within the subacomial space, I generally like to range the shoulder to make sure that the implant is in appropriate position and stable. You can see because of the clear nature of the implant, we can actually visualize the tuberosity through the implant itself. We work on gentle range of motion, both internal, external, abduction, forward flexion, and you can see the implant remains stable through range of motion, articulating between the humeral head and the acromion. At this point, the procedure is essentially complete. The next step would be to remove the camera. You would close your arthroscopic portals per standard fashion, apply a sterile dressing, and the patient is placed into a standard arm sling.